morning. Thank you everyone for coming today. I'm really excited to share with you how I help patients in my practice, optimizing health and people with individuals with Down syndrome. My name is Dr. Erica Peirson, and I am here on behalf of Down Syndrome Options. I'm also the executive director of Down Syndrome Options. We are a nonprofit organization who has come together to actually bring together researchers, clinicians, and parents like yourself to have a broader conversation on how our children with Down syndrome can be helped. And the work that we've been doing just in the last year has been really exciting. Our annual conference this year, we're actually partnering with researchers at Arkansas Children's Hospital. I'll mention some of their work today. And we're bringing together, again, researchers from around the world, clinicians like myself, to be talking at our annual conference in June of 2015. So that's Down Syndrome Options. And so I'll use the term our children throughout this talk because I'm here today because I have a son with Down syndrome, to tell you a little bit about my background. I'm a naturopathic physician, licensed in the state of Oregon as a primary care physician. My medical background and training is an equivalent to that of a medical doctor. And so the state of Oregon recognizes that, and I'm a licensed primary care physician there, full prescription rights, et cetera. So I became a naturopathic physician in about, 2007, the same year that my son was born. And so when he was born, not the first thing that I did a lot of things first. But shortly after he was born, I dove into the biochemistry of what's going on. How can I help my son? How can we optimize his health? And I did get a prenatal diagnosis. I loved and accepted my son for who he was. I just wanted him to be healthy, right? That's a really important concept I want to make clear today, is that Down syndrome options, me as a practitioner, those of us here today, I'm sure, we're not trying to fix, cure, or change our children, right? We love them for who they are. We just want them healthy, right? That's our goal. That's my goal. So I have a son with Down syndrome. He actually has mosaic Down syndrome. He's 7 years old now because it's 2014, and I started in 2007 in my practice, and then shortly thereafter he was born. So I started to study the biochemistry of what's going on, and there's a lot out there. I was fascinated by, especially after going to my local Down syndrome clinic and asking them about vitamins. Just as what about vitamins? I've heard some talk about vitamins in children with Down syndrome, and the quote that I have is that vitamins don't work, as though they don't have a function in the body, right? Not even asking me what my goals were, what deficiency I was looking to address, just that they don't work. And I think that's the general consensus out in the conventional medical world regarding Down syndrome, is that our children's health, their health issues and symptoms are dismissed, right? They're written off. It's just Down syndrome, right? And yes, there's an extra chromosome. We all are aware of that. And we can't change that, but boy, there's what we know about it. I'm going to teach you today as best as I can, right? So that's a little bit about my background. And when I started treating children with Down syndrome in my practice, I was doing this for a few years with my son. He was doing beautifully. And I thought, gosh, I need to help some other kids. So I opened up my practice to seeing other children with Down syndrome. Thought I could, help their digestion a little, their immune system, respiratory function. I had no idea I could do what I'm doing today. I had no idea what I'm doing is possible. So I've started out my talk here with a couple of testimonials, just to kind of grab your attention, to reinforce why we're all here today, of some testimonials of some patients that I've been helping, and some cut and paste from the parents' email. So this is a 16-month-old girl with Down syndrome, full trisomy 21, and mom just wanted to give me an update on her daughter. I took her name out, of course, and she started her treatment about 1 month in. And this is what she saw. Mom put this in bullets, and I was like, I'm so going to use this when Mom listed it like this. Her reflux was gone the first day. right? Do you all know how common reflux is in our kids, right? First teeth came in, she was 16 months old, right? The first teeth are supposed to come in 6 to 10 months. She was 16 months old and still had no teeth, right? So delayed dentition. Her first teeth came in the first week, and the second tooth, the second week. Pulled herself to standing on the first day of the treatment. Stood up without support the second week. Her tongue protrusion was greatly reduced. Crawling, she greatly increased the distance that she had been crawling. She was more curious. She was dumping out things all over the place. Parents were happy to see that she was making a mess around the house. And her appetite has increased. And so Mom said, thank you for understanding what she needed. So all of these things, so someone might argue, well, those are just normal parts of development, right? Teeth come in, children start standing. This happened in 1 month, right? And a 16-month-old. And the parents have been waiting for these milestones. So that was pretty exciting. This mom, again, I do tend to see a huge range of patients, any range. I get moms who are pregnant with children with Down syndrome up through adults. But I tend to get a lot of kids who are around 16, 18 months. So this little boy was right in that age range, about 18 months. And so she said she touched upon some of the developments during our visit, but she wanted to list them in this email. He picked up about 10 signs. They use sign language. Again, this is since we started, this was 3 weeks. In 3 weeks. He picked up 10 signs, got better at drinking from his cup, went from 2 to 1 nap a day. He was less fatigued, right? Started using his pincer grasp. You guys know that one, the pincer grasp? Able to eat smaller things on his own, more imitations of speech and gesture, waving hi and bye. And he started showing more interest in movement and trying to crawl. He was more motivated. He was just less tired, too. So thank you so much, right, from this mom. My next kiddo, just one more testimonial. This one is a little bit more laid out. This mom has a blog, and she gave me permission to use his name and his images, and I've got videos. This one's pretty cool. This is Sam, right? Super cute. Again, about 16 months old here. Many of the symptoms that we see in our children with Down syndrome. He had low muscle tone. He had what's called beta-carotenemia. Has anybody ever heard of that? Beta-carotenemia, which is an orange color to his skin, right? I'll talk about it later, kind of the third part of our talk today. He had cold hands and feet, dry skin, delayed growth. He had no weight gain in 6 to 8 months, and he was all 20 pounds in 24 months, at 24 months old. Difficulty swallowing and delayed speech. Sorry, yeah, he was 24 months old. I said 16 months old because he looks a little bit younger, right? And then more. Right? There he is. Do you see that little orange nose there? Do you see how it's slightly orange? Yeah. Fontanelle closure after 2 years old. The fontanelle, the soft spot on the head, it should close by 2 years old. His was still open. I had one child I was working with at 3. His fontanelle was still open. So that delayed fontanelle closure. Delayed dentition, his teeth came in late. Family history of hypothyroid. He had reflux, history of Zantac. And he actually ran a bit warm. He had some temperature dysregulation, right? And he had mottled skin. Do you all know what mottled skin is? It's that kind of puzzly, lacy sign of circulation issues. There's some red patchy, some white patchy areas to the skin. And I should add, too, before I continue with Sam's case here, is that if you have questions, I apologize for not doing this sooner, if you have questions, to put them on the index cards, and I will answer them in between breaks here. We'll take a couple of breaks today, and I'll just bring them up to the front here, and I'll gather them, and then I'll answer them at the next section. So there's another picture of Sam. I don't know if you can see a little bit of the orange. I chose this picture because you can see the palms of his hands and the soles of his feet a little bit. I don't know if you can see that on the screen there, but he's a little bit orange, right? And that beta-carotenemia does concentrate around their noses. It's kind of funny. And the palms of their hands and the soles of their feet. And sometimes on the ears. Kind of thicker skin. So this is Sam. I'll talk about those
Daddy
numbers.
is very excited to hear about this.
This is great. So he's not walking yet,
Look at
24
me,
months
I'm
old.
sitting right here. You can come get me.
Low muscle tone. Look at him.
Come get the
He's kind of scared.
mamas.
He's a little scared.
Oh, so close.
So his first steps, right, he kind of fell towards mom. And that's typical for our kids. Ignore those. That's typical for our kids, to not be walking till they're 24 months old. Please, I'm sorry, please ignore those. His TSH, right? This is thyroid stuff. I do a lot of work in the area of hypothyroidism and all. That's the last thing I'm going to be talking about today. His TSH was 7.3, and I'll explain thyroid stuff again in the last half, but that's elevated, and his doctors weren't treating it, right? His doctors weren't treating it. Let's just wait. There's actually a study out there that says that children with Down syndrome tend to have elevated TSH, and it's a normal variant for Down syndrome, and you shouldn't do anything about it. Are you kidding me? Right? This is hypothyroidism in a child. This is the biggest work that I do with these kids. And again, I'll explain this later, but his reverse T3, which is a bad form of thyroid hormone, was elevated at 23.8, right? He had some issues going on in his body that was causing his thyroid hormone to not function properly, and I'll explain it more later. And one last thing there is platelet count. See the PLT there, 576, that's elevated. It's a sign of hypothyroidism. Okay, I don't have the studies in this PowerPoint today, but it is. And so this is 3 weeks after treatment.
All right, stand up.
See his numbers there?
Look at you! Yay!
Yeah, he was getting there already,
Good
right?
job.
But you guys know, I know with my son, the walking, it's a
Yay!
little bit of a stop-start,
Okay.
right? I thought that was pretty cool, right? And she blogged about it. Okay, let's skip those. Oh, but his TSH, right, after proper thyroid treatment, down to 1.94. His reverse T3 was 23.8 before, and now it's 17. Right, that reverse T3, that's a bad form of thyroid hormone that doctors aren't checking for. I check for it, and I'll explain it later. Yeah, so that's Sam. And then there's more than just the walking. This is, again, from Mom's email. Amazing progress in 3.5 weeks. He's been on the meds. After starting his meds, he took his first steps, as we saw, almost immediately. Now he's been walking 10 to 15 steps unassisted at a time. His early intervention program commented his strength seems much better, added new words, went from 3 to 4 words in 3.5 weeks. He's signing more, and his play was more mature, right? Instead of just banging toys, he's actually engaging in pretend play and imitation, which is a really good sign of some cognition shifting, right? Which isn't always my goal, right? Honestly, cognition is not always my goal, right? I just want our kids healthy, right? And some of our kids with Down syndrome, right, are struggling with health issues. A lot of our kids are doing great, right? But kids that I see, can struggle in their health issues, and so when we do get some cognition changes, it's really exciting. Yeah. So those are my testimonials, right? And I've got tons of those, right? I call them the oh my gosh emails. The parents email me, they're, oh my gosh, I didn't know this was possible. So why treat Down syndrome, right? Again, a lot of conventional medicine will dismiss the symptoms. Perhaps you've all heard it, right? Well, that's Down syndrome. Oh, your child's constipated? Well, let's give them Miralax, which increases dementia, by the way. That's Down syndrome. Let's just manage it the best we can, right? All those symptoms that we bring to the doctor. So why treat it, right? Treating patients is different than curing patients, right? So in treating, we're addressing underlying biochemical imbalances. As a naturopath, that's how I treat, right? I'm not suppressing symptoms. I'm not putting Band-Aids on things, right? I'm treating, and I'm not curing Down syndrome, right? Just want to be clear. We're not removing that extra chromosome. We're not changing our children's personalities. We're not altering them in any way. We're just treating imbalances, right? Biochemical imbalances. So it's a little bit of a harsh picture, but it's often how I feel about conventional medicine, treating and researching the biochemical causes of Down syndrome, right? And when I say the causes of Down syndrome, I mean the causes of the symptoms of Down syndrome, not the cause of that extra chromosome, although I've got some thoughts about that too. The research has largely been ignored by the medical community for years. It takes 17 years, there's a study about this, literally. It takes 17 years for research to get into clinical practice. 17 years, right? I'm going to talk about some studies that came out as recently as October, and I was talking about them in October when they came out. So I keep my finger on the pulse on what these researchers are doing and what they're uncovering, and we're using it. We're using the information pretty quickly, but the conventional medical world doesn't always look at them. I don't want to paint them in a poor light, but the research is there. So this is a PowerPoint, or sorry, an image indicating the amount of money that is put towards Down syndrome research, right? If we look at autism, there is $302 per patient. This is per patient, right? $50 for Down syndrome compared to cystic fibrosis, Huntington's, ALS, muscular dystrophy, autism, etc. Right? Very little money towards Down syndrome research. And perhaps you're all familiar with the Down Syndrome Research and Treatment Foundation, now called Lumind. They're doing some pretty great work. They are looking for drug targets. That's not necessarily my take on things, but they are doing some pretty great research, also looking at the underlying biochemistry of Down syndrome. So it's the most common congenital anomaly. I choose that word carefully, right? It just means that something's different, right? I hate the word error or mistake. That's horrible terminology. So I chose that word carefully, anomaly. It's just something different worldwide, but the least funded for research, right? Right? So I've already kind of gone over this. There's symptoms, right, in the doctor's office. Perhaps you've all been there when you have concerns about your child's growth or their dry skin or their constipation or why this, and they're just dismissed as normal for Down syndrome, right? But I've been able to affect all those, many of those symptoms. Ameliorate is the other word I like to use, right? Ameliorating symptoms, meaning just improving them, right? Not always curing, fixing, changing, right? And so this is a really important concept. This is that nature versus nurture, right, concept, that nature is our genetics, nurture is our environment, right? And our health is often dictated by both, right? And in fact, science, we're unable to tease them apart, how much of each dictates our health. So our genes are not the end-all be-all of our health, right? That extra chromosome, you don't shut the door just because there's that extra chromosome. We've done what we can, love your child, and do the best you can to manage the symptoms. I hate that one. Just love your child. Like I need to be told to love my child. And so our genes are not the end-all be-all of our health, right? There's so many more factors, diet, lifestyle, nutrition, supplements, we'll get there, right, that can impact our health. And our children with Down syndrome are no different. So this term genetic overexpression, right? So we're talking about an extra chromosome, chromosome 21. So overexpression means that the genes on that chromosome are running at 150%, right? Because we have an extra 50%, right? An extra chromosome. And so that chromosome isn't just sitting there stagnant in every cell of their body. It's producing, that was where I started with this. I'm like, well, chromosomes, genes, they make proteins. Well, what proteins are being made? What proteins do we have too much of in the body? And that's what we look at, this genetic overexpression. So our genome, right, our entire genome was decoded in 2003, right? A lot of just an avalanche of research after that, not only in Down syndrome but other genetic conditions, right? Where they know what proteins are coded for on chromosome 21. We don't always know what these proteins do, but there are a couple of key proteins that are coded for on chromosome 21 that we look at. I'm really only going to focus on one of them today, but I'll talk about the other one just briefly as well. So they've been able to also narrow down the area on chromosome 21. It's not the whole chromosome, actually, that creates the phenotype, right, the appearance of a child having Down syndrome and the symptoms that often come with that, to just a piece of that chromosome 21. And that's based on children who have translocation of trisomy 21, where just a piece of that extra chromosome is attached to another chromosome. Do you guys know about translocation? Right? And so they've been able to narrow it down based on those little pieces, right? How much of that chromosome is sort of needed to create the phenotype meaning the appearance that we see of Down syndrome. And it's called the DSCR, the Down syndrome critical region. It's a chromosome. I'm going to show you a lot of technical pictures, but I'll explain them all. This is a chromosome, right? And it's just on the terminal end there, that bottom part. That's the DSCR. It's the white, black, white area. And so they've pulled out all these See, they're all coded, all those proteins. There's a couple of key ones. The top one, the SOD1, there, the top one in the letters there, that's the major one I'm going to talk about today, SOD, and what it does and what it means and all that. So just an overview of the three, I'm going to break this down into 3 sections: genetic overexpression and oxidative stress. That's the first topic I'm going to talk about. Then we'll take a quick break, about 10 minutes, and then I'll gather your cards and answer questions right before I dive into methylation. And then again, we'll answer questions right before starting hypothyroidism. Yeah, so that's what we're going to look at today. So Down syndrome, I often abbreviate it DS, is caused by overexpression of genetic material. I already explained this, but the role of genes is to make proteins, right? So what proteins are being overproduced, right? The most important one, in my view, is SOD, right? There's also one called DYRK1A. I call it DYRKA. I don't know how other people pronounce it, but when I see it, I say DYRKA. DYRKA1A. It's a kinase, and it has some implications into health and cognition as well. And we have ways of managing that, but I'm just going to focus on SOD today. So SOD is short for superoxide dismutase. Any word ending in an ASE is an enzyme. I'm going to talk a lot about enzymes today. And it's a free radical scavenger, right? So it hunts down free radicals and removes them from our cells and our system, which you would think would be a really great thing, right? That's great, SOD removing free radicals. But there's an imbalance because we have too much SOD, and it's converting these free radicals to hydrogen peroxide, right? So SOD works really closely with another partner enzyme called glutathione. Have you guys heard of glutathione? Yeah, it's a really important one here. SOD is on chromosome 21. Glutathione is on chromosome 20, okay? And they work together. So this hydrogen peroxide that SOD makes is converted to water by catalase, another important enzyme, and glutathione. So hydrogen peroxide is damaging to cells, right? You all may have some hydrogen peroxide in your medicine cabinet at home, right? And you put it on a wound maybe to kill the germs right when that wound happens, right? And it kills those germs because it kills cells, hydrogen peroxide. And nurses know this, if you were to continue to put that hydrogen peroxide on that wound, it wouldn't heal very well because it damages cells. So we need to clean that hydrogen peroxide up, and we do that with glutathione in every cell of our body as we speak, right? This is happening in your body, okay? So we get an imbalance, so we get a buildup of hydrogen peroxide in the cells of our kids. And I'll talk about what that effect that has on the body. So the gold standard for treatment here is glutathione in helping our kids with Down syndrome. And I'll tell you, the anti-aging camp, right, Suzanne Summers and all those guys, the anti-aging folks are totally looking at glutathione too. A lot of neurodegenerative conditions, they're looking at glutathione, right, anti-aging, all that. And so it certainly does not, it certainly applies to our children with Down syndrome as well. So the problem, right, the gene for that makes glutathione is on chromosome 20, right? So that's being upregulated and expressed in kind of a normal rate, right? But we've got too much SOD, and I've got lots of kind of biochemical charts and things, but I'll point things out. I'll probably have to go up to the screen and point them out. I don't, oh, I do have a laser pointer, okay. So this creates the imbalance and a buildup of hydrogen peroxide that's damaging to all cells. Here's a study. I've got as many studies in here as I can to support all of this information, but this is well known, well established with Down syndrome. So yeah, lots of studies. I don't often, it's a little blurry, but I don't often make recommendations without some study or some support for why this should be implemented in our kids. So there's a blurry image of the superoxide dismutase, that's SOD, right? This is a free radical. This is oxygen, and that little dot right there that I'm just kind of shaking on, I'm going to talk about what oxidative stress is. This is going to be your chemistry lesson for this morning, just to really kind of get some basic information out about what oxidative stress really is. But this guy is bad, right? Superoxide dismutase comes in, turns it to hydrogen peroxide, which is H2O2, and this glutathione peroxidase turns it to water. Awesome, great, this two-step process, right? And this glutathione peroxidase has to be recycled, okay? This is your first kind of big biochemical pathway. So this is kind of opening what you just saw and kind of expanding upon that a little bit. I'm just going to break this down one step at a time here. This is that oxygen with that little dot there. That's an extra electron. And I'll talk about these electrons and how they're funny little things. They like to travel in pairs, right? And here we've got one that's by itself, and that's a bad thing. An electron by itself is a bad thing. I know it sounds odd, but it's a basic tenet of chemistry, is that electrons are seeking partners and stability, and this guy is not good for the body, okay? So here's that SOD converting it to hydrogen peroxide. Here's glutathione getting it to water. Catalase also converts it down to water, okay? And if this doesn't happen, we get a buildup here, and then hydrogen peroxide is not only damaging itself, but hydrogen peroxide converts to another free radical. There's that extra little dot that has a lot of negative consequences in the body. And we're experiencing this, right? It's why we're aging, right? We're experiencing it too, right? But our kids just kind of have a little bit more, right? So we've got some DNA damage. And so I got to present the bad news first, but then I got the good news, right? What we do about this, right? We have ways. So we have damage to DNA, damage to mitochondria. Have you guys ever heard of mitochondria? These are what are called the powerhouse of your cell. Every single cell of your body has mitochondria in it. Just about every single cell, not every cell. And they make energy. They are the little just generators for every cell of your body. Really cool. I study mitochondria pretty heavily. And the area of the body that has the most mitochondria, that's using the most energy throughout the day, some people always think the heart. It's the brain. The most mitochondria. So this happens, right? And then we get lipid peroxidation, which is fats. Lipids are fats. And this is oxidative stress that happens to fats in our body. And I'll tell you in a little bit where those fats are and why this is so important. So that's a really important process. So then what is oxidative stress, right? You know about glutathione and superoxide dismutase and how they kind of clean it up, right? So the textbook definition, oxidative stress is a disturbance in the balance between the production of reactive oxygen species or free radicals. Those are those guys that have that extra, that unpaired electron, right? You guys are in the know now, right? You've got some science background now. It's an unpaired electron. And then our antioxidant defenses, it's an imbalance in that. And there's a couple things. Antioxidant defenses, part of that is that SOD glutathione. And part of that is antioxidants being present in the body in the first place to prevent these free radicals from even forming, right? And I'll talk about those antioxidants too. So it's an imbalance. So I got to talk about electrons, right? So I teach at community college, or I did until recently because I've gotten busier with this work, but it's hard for me not to bring my teaching into my medical practice, and certainly these lectures today. So we're talking about electrons, right? And I'll tell you what, guys, electrons, they're the coolest little things. We would, like, our whole world right now as we are sitting here is dictated by what our electrons are doing, right? How our atoms are connected to one another. It's pretty cool. So this is kind of it right here. Oxidation, right? Since we're talking about oxidative stress, oxidation is the loss of an electron. And when you lose that electron from an atom, that compound is losing energy, right? So here we've got compound A and compound B, right? There's something, like maybe it's an oxygen and a hydrogen or something. And they are neutrally charged, right? This guy, A, is going to lose an electron, right? And then he becomes positively charged. B is going to gain that electron. You can't lose an electron. The electrons don't just float around, right? Something's pulling that electron, right? So this B was what stole that electron, right, from A. So the agent that took that electron is then reduced because it gained the electron. So these are called redox reactions, reduction and oxidation. Really important. It's about the transfer of an electron. Really important concept, especially in oxidative stress, right? And our biggest, let me see if I have that on the next. Our biggest sort of stealer of electrons in the body. When I teach this, again, at community college, I talk about oxygen being an electron hog. Oxygen will just grab an electron wherever it can, and an extra one, right? So oxygen in the body, when you breathe it, has to be highly controlled and highly protected, right? Because it will form these free radicals just like that. So as I've already kind of established here, atoms are most stable when they have a complete set of electrons in their outer orbit. They're seeking stability, right? And they want that partner, right? Personify my electrons. They're seeking a partner, right? As we often do. And so this is a normal consequence of chemical reactions in the body, atoms losing electrons. This is happening all the time in our body, right? These redox reactions, losing, gaining electrons. It's happening a billion times over in this room within our bodies, right? So it's normal. So these atoms that have lost an electron are called free radicals, right? Very unstable, seek out electrons to complete that outer orbit, right? Once they've lost that electron, they want it back again, right? They want that partner back. And as well, that oxygen that has taken that electron, that is also unstable because it has that single electron on it, right? So we get a bit of a chain reaction, right? When that oxygen steals an electron, right, and it leaves behind a compound that needs an electron, it just causes this chain reaction of oxidative stress. So what do we have for this, right? We have antioxidants, right? You guys know about antioxidants, right? Right? We're always told to eat our antioxidants, our colorful fruits and vegetables. Well, what exactly does that mean, right? They're compounds that have extra electrons in their outer shell, right? When you eat your antioxidants, you're eating extra electrons, right? Vitamin C, vitamin E, they have extra electrons in their outer shell that will satisfy those free radicals, seeking that extra partner electron. So they have extra electrons in their outer shell, satisfy their free radicals' need for electrons, making them less reactive. That's how they work. It's about electrons, right? Kind of complex, but basic at the same time, right? This is an image I've posted this on I have a Facebook page, and I put out as much as my time allows me to on there to educate. I did a series of posts about oxidative stress, and I used this image because this is great. This is an antioxidant, right? Look at all those extra electrons in its outer shell. It's happy to donate one of those electrons. This is a molecule of oxygen, right? 1, 2, 3, 4, 5, 6, 7, 8 in its outer shell. And so this electron, right, would have been unpaired if this antioxidant didn't donate an electron. And this would have been what's called a reactive oxygen species, and it would have been really damaging. I almost picture them like they're bouncing around like pinballs, just like knocking things over and just kind of causing destruction on a really microscopic level, of course. So these are also reactive oxygen species. They come in many forms, unfortunately. Here's what oxygen normally looks like, right? They're sharing electrons here. Everything is paired up. It's really happy. And then, boop, it grabbed an extra electron here. These red ones are extra, and they're the damaging piece. So this is superoxide anion. Here's a peroxide with 2 electrons, again, like hydrogen peroxide. There's that hydroxyl free radical. That's the most damaging free radical in the body, is this hydroxyl free radical. Right? So we've got several forms of these sort of damaging free radicals, right? Does that make sense, right? It's all about electrons. Kind of simple, hopefully, for you. So oxidative stress. So that first image I showed you with those pathways showed that off to the right here that DNA was damaged, and then we had lipid peroxidation. Right? This is the damage to DNA that occurs. Again, it's happening in our bodies right now, right? We get, here's that hydroxyl free radical. It's seeking out an electron. And where it will find it, oddly enough, is on our DNA. It will share this electron. It'll go, oh, there's an electron. I'm going to grab that. And now it's happy. It's satisfied, right? However, this changes the shape of this DNA, which damages it, right? You change the shape of DNA and you're in trouble, right? And it damages it. And it's called 8-hydroxy. That's a hydroxy. It's on why the 8? Probably because it's on carbon number 8. 8-hydroxy deguanosine, right? cool thing about this, we can test this in urine. All of you, anybody. We can get a urine sample and see what your oxidative stress level is. Because what the body does, we've got damaged DNA, but the body is really cool, really smart. It has mechanisms that can remove this damaged DNA, right? Little like machines. Our cells have just run like fine-tuned machinery. So these enzymes on DNA will come along and be like, "Oop, that one's not right, that's damaged." It will remove it, put in a new piece of the correct DNA without that hydroxy on it. So it removed that damaged DNA. Where does that removed damaged DNA go? Out your urine, right? You pee it out. 8-hydroxydeguanine, highly studied, and lots of research on 8-hydroxydeguanine, not used clinically, right? Although I use it. Right? Other practitioners use it too, yeah. So the other area of the body that is most susceptible to this oxidative stress are cell membranes, right? And cell membranes are like the skin of a cell, right? Just like you have skin on your body. Cells are cool. We can find a lot of analogies to cells, to our own body. Cells have a stomach. They have energy producers. They have skin. They have cytoskeleton like we have skeleton. It's really cool, the analogies between cells and our body itself. But they have a skin. Cells do, and that skin is made up of what are called phospholipids. So there's that lipid, right? A lot of fats within your cell membranes. And these membranes aren't just on the outside of the cell, they're also within the cell, they're on the mitochondria, right? They're all part of that cell, and they're highly susceptible to damage because, sorry, that's a complicated slide, right? I'll get to that. So this is a phospholipid. Right? There's what's called a phosphate here. Don't totally need to know about that just yet. But all these chains, these are fats. That's how fats look in our body. They're just links of carbon and oxygen and hydrogen, right? And they occur in our cell membranes in 2 layers. I've got a picture coming up. But basically, they're broken, right? Here's that reactive oxygen species. It comes in and says, hey, there's an electron. I'm going to take that one. And it breaks the cell membrane. Literally, cell membranes are broken by these reactive oxygen species. And then there's a chain reaction that occurs, because guess what? There's an electron here that's unsatisfied, right? It's going to break another cell membrane, right? Phospholipid. So we get this damage to cell membranes. And again, this happens in all of us, right? The body can repair this, right? It just happens at a higher rate in our kids. And we need to provide the right building blocks so that it can repair these cell membranes, and the right antioxidants and compounds to help prevent this from happening, right? Another complicated picture, right? So I took this picture and made it even more complicated, right? This is the first one that we looked at with that free radical with those extra electrons. There's that hydrogen peroxide. There's glutathione and water, right? So it's that same image. And you've got this on your handout. We'll post this online for those of you who are going to be viewing this online. But I just explain kind of all the steps here. The writing is really tiny here. Can you guys read that on your handout okay? I had a lot to put on here. So, but here I talk about how the gene for SOD is on chromosome 21, right? We've gone over that. Produced in all cells of those with Down syndrome. It's overproduced, right? And then we get these oxygen-free radicals that are normal in the body. Produced a byproduct of normal cell metabolism, right? Neutralizing these oxygen-free radicals in the first place is accomplished with antioxidants like vitamin C and vitamin E. If we can stop right here in the first place, great, right? Wouldn't that be great to even prevent this from even happening, from even needing to use these, right? I don't have the studies in this presentation, but just by providing these free radicals, the body will downregulate, produce less SOD. It says, I don't need to use this, right? The body's really smart. It can read what's going on at many levels. And so if we can reduce these in the first place, then we don't even kind of go here, right? So, of course, we get increased levels of hydrogen peroxide, right? This is a little bit of review, right? Production of catalase and glutathione peroxidase need to be supported and optimized in order to keep up with higher activity of SOD, right? This is the key here, right? Because the hydroxyl free radicals are produced from hydrogen peroxide that did not get converted to water, And these free radicals, unfortunately, are the most reactive free radicals in the body, right? And here's what they do. They damage cell membranes like you saw, literally breaking them, and they damage DNA by changing the shape. And mitochondria are damaged because they're made of the same cell membrane, right? They're damaged. And so cellular death doesn't always occur. There are repair mechanisms in the body, but if the repair mechanisms are not supported enough, not sufficient enough, cell death can occur, unfortunately. And again, our bodies are doing this. I don't want to scare you too much with this information, but we've got ways of helping this, which you've seen already. So I've broken down lowering oxidative stress into 3 steps, right, to help kind of simplify this complex process. And I've already said all these things already. Preventing free radicals in the first place from forming with antioxidants, right? Supporting that SOD glutathione system by optimizing glutathione levels. You can optimize catalase too. We focus on glutathione because it's more strongly converts hydrogen peroxide to water. Catalase you can take as a supplement, but I've only been able to find it where in the supplement, it's SOD and catalase. I'm like, I don't want the SOD, I just want the catalase. The third step is providing the building blocks, right, for repair should that damage from free radicals occur, right? Particularly cell membranes. So 3 steps. So the next 6 or so slides kind of look like this, but they're studies, right? This is what I read all day long. Study, study, study. And I've pulled out some key, you don't have to read all this. I've pulled out some key phrases here. So this is a study from 1998. Kent MacLeod was involved in this. He's a pharmacologist from Canada. I highly respect his work. He also works with children with Down syndrome. And so they did this back in 1998, and basically they just said these results provide direct evidence for increased oxidative stress in children with Down syndrome. And what they were testing here, this big long word here, 8-hydroxy-2-deoxyguanosine, right? That damaged DNA, right, in urine. They checked it and they said it was higher, right? And they also checked, malondialdehyde, right, which is a marker of that cell membrane. You don't need to know malondialdehyde exactly, but a biomarker of lipid peroxidation, right? Those 2 things that I just talked about, completely different, images slide. That image didn't come from this study. This is what researchers look at for markers of oxidative stress, and it was increased in individuals with Down syndrome. So that's been established, 1998. 2007, just another study, lipid peroxidation in Down syndrome, right? Our results confirm an increase in lipid peroxidation in patients with Down syndrome. Okay, so yes, so we've got some bad news, but the next studies, not this one yet, but this was a mouse model, right? They've been able to genetically modify mice to have Down syndrome. Are you guys aware of these studies in mice? Chromosome 16 in mice correlates with chromosome 21 in humans. And so, and they get a lot of the same biomarkers and processes in their body in these little Down syndrome mice, mice with Down syndrome. So they have increased oxidative stress, and they were able to impact, right, in a mouse model, cognition, right, in these mice. They can test their memory in mazes and things. I don't even know how they do it. I don't do the research stuff. Provides evidence that vitamin E delays the onset of cognitive and morphological abnormalities in a mouse model of Down syndrome may represent a safe and effective treatment early in the progression of Down syndrome neuropathology. That was 2009, 5 years ago. So I don't know, right? When I went to the Down syndrome clinic in Oregon, and they said vitamins don't work, maybe I just wanted to lower oxidative stress in my son, right? Vitamins do work. But that's just a mouse model, right? So 2014, just June of this year, this was really cool, right? They're looking at all this SOD, glutathione, T-bars are a marker of oxidative stress, and they're using vitamin E, right? Antioxidant therapy, right? They're checking all these. They're not looking at 8-hydroxyguanosine and lipid peroxidation. They're looking at other markers. So the cool thing about this statement, clearly, right? This is a research study. These strong words aren't often used. They're often kind of like, well, maybe this could be considered for therapy, right? This is really a strong statement. Our results clearly demonstrate that the antioxidant intervention with vitamins E and C attenuated the systemic oxidative damage present in Down syndrome, right? Vitamin C and vitamin E. If you do nothing else, right? Here's another one. Again, October of 2014, just two months ago, right? Alpha tocopherol, which is vitamin E, supplement reduces biomarkers of oxidative stress in children with Down syndrome, right? So these last two studies, they're checking in actual children. It's just vitamin E, so there's no ethical harm. 93, which is a pretty decent number, right? Age 7 to 15 years, boys and girls. They used alpha tocopherol, vitamin E, and another supplement called alpha lipoic acid, right? And they used, the dose is right here, 400 international units a day, okay? So this is a little bit more, okay. So although urinary 8-hydroxy concentrations decrease significantly with both of these supplements, right, vitamin E and alpha lipoic acid, the mean final levels of this marker differed significantly, again, a really strong word for a research study, only between alpha tocopherol and the placebo group. So basically they're saying we tried a couple of supplements, compared it to kids who got nothing, and it was really the vitamin E that had the biggest impact. That's what that's saying. All my patients, vitamin E, right? I often recommend 400 IUs in children who are 4 and above. I'll talk about some specific supplements. In children who are about 2, I'll go 200 IUs. Infants, I'll say about 100 IUs, right? So I'm using that study, right? If they can show that it lowered it, I'm going to use it right away, right? So the very first step, remember, of oxidative stress is preventing those free radicals in the first place. Vitamin C and vitamin E, we showed that we can do that, right? But how do we support glutathione levels? This is a little bit controversial in the medical world, supporting glutathione levels, because a lot of people are looking at glutathione. So for years, people have said that you can take glutathione pills, but take glutathione in a capsule, swallow it, and then it will increase glutathione in our cells. But for years, they said there's no absorption through digestion of that. It gets kind of broken down in digestion. And so we all scratched our head, well, how do we get this glutathione in these kids, right? You can give an IV, but who wants to do that in a kid every single day, right? They need this glutathione like every day, right? You can give it through nasal inhalation. You can give it through, respiratory inhalers, but those don't always get it completely into the blood. So we've always scratched our head. It was the gold standard to increase glutathione levels, but it was always like, how do we do it, right? Well, this study came out in May of this year, right? We were all up in arms. We were all really excited about this. What they found, they gave people oral glutathione. While oral glutathione has been shown to be bioavailable in lab animals, its efficacy in humans has not been established, right? Taking it as a pill, you can get pills of glutathione online, right? But a lot of practitioners were saying it's a waste of money, it's not absorbed. This study, these findings show for the first time that daily consumption of glutathione supplements was effective at increasing body compartment stores of glutathione. Phew. We can take it orally. It's really best taken in a capsule. Much of the work I do a lot of concoctions in my kitchen. I'll tell you what, opening up these capsules, how does this taste? What can I mix this with? I have so many supplements at home, not just for my own son, but just making little concoctions in my kitchen. Glutathione doesn't really taste very good. It's a very sulfury compound. So as soon as a child can swallow capsules, I know, can be late for some kids, but we worked really early on that with my son, on swallowing capsules. But it can improve glutathione levels just by taking it orally. A lot of the studies used Cetria glutathione, Cetria glutathione. And based on the doses used here, I've got doses coming up. I'll tell you about glutathione. So then cell membranes, right? So the first step, right, prevent free radicals in the first place. Second step, support glutathione. We can support glutathione by more than just taking it orally, right? And that's the whole second part of this talk, which is methylation. I'll get to that, how we can support the body from making its own, and that's methylation. So our third step is these cell membranes. So I just wanted to show a picture of these cell membranes, right? Here are those fats in the middle here, those kind of long tails, we call them, hanging down. We've got two layers. They're kind of mirroring one another, right? We've got phosphates here and phosphates here. And then we've got, sorry, these are kind of straight up and down. These are upside down. See how there's two layers kind of sandwiched together? So these are all fats in here. Cell membranes are hugely complicated. I cannot even express to my students how hugely complicated they are. And they're extremely dynamic. There's a lot of business going on in our cell membranes. Stuff is moving around, stuff is coming in and out, stuff is changing and shifting, oxidative stress is happening, repair is occurring. They're busy, busy places. So what I wanted to show here is that these phospholipids, right, these fats, there are several different forms of them. That's the key point here. Phosphatidylcholine, phosphatidylserine, phosphatidylinositol, and phosphatidylethanolamine, right? These are all phospholipids found in our cell membrane in different concentrations on either side of the membrane. So when there is damage to these cell membranes, I want all of these phospholipids available, okay? A lot of parents in the biomedical world of treating children with Down syndrome, a lot of parents are already out there, and they're probably watching this, and they know all this stuff. A lot of parents are giving just phosphatidylcholine. And there's a lot of support, a lot of research supporting that phosphatidylcholine helps support cognition. Other neurodegenerative researchers are looking at this in terms of Parkinson's and Alzheimer's and other conditions. But I like to give other phospholipids as well, sort of a complete phospholipid supplement. And I'll talk about what that is in a minute. Sphingomyelin is another phospholipid that's found in there. I haven't used that as a supplement yet, but I'm looking at it. Some parents are using it. Again, a really dynamic structure, right? Here are those tails. I could not put this in these. There's so many cool limits. It's my favorite concept of biochemistry, or cell membranes. And so, because it's so important. And it's actually our cell membranes that dictate what happens in the cell. The receptors, things coming in and out. It's not the nucleus, right, where the DNA is. It's cell membranes that are really running the show. So it's really important. So here are all those membranes. They've kind of pulled it apart here image-wise. There's receptors in there, channels coming in and out, markers on the surface identifying the cell, all sorts of things going on here. And here it's talking about the fatty acid phospholipid here, right? Hopefully well established for you. So what do I do, right? Step 1, step 2, step 3 of oxidative stress. I've tried to simplify it as much as possible. There's a lot more to it than this, okay? I have to tell you, there's a lot more to it than this. There's CoQ10, which helps support mitochondria. There are many antioxidant supplements out there. But just in terms of research and for the purpose of the scope of this talk, I pulled these out. Vitamin E, of course, well established. 400 IUs a day was used in the study. Vitamin C, I get this asked a lot. How much vitamin C do I give my child? And I've kind of gone back and forth with my son too. Clinically, what we often say about vitamin C is to bowel tolerance. You basically give as much as the body will take. And when we say bowel tolerance, if you, I've done it, were to take too much vitamin C, you get loose stools, okay? And not in a crampy, oh my gosh, immediate, urgent kind of a way. It's just it loosens the bowels, which kind of nice for kids who have constipation and Down syndrome. It's my number one remedy for constipation, other than addressing their thyroid and the initial cause for their constipation. But vitamin C, we give as much as their bowels will absorb without causing too loose of the stools, right? And for every child, right, that's going to be different. Every adult, every person, that's going to be different. I give my son 1,000 milligrams of vitamin C a day. He's 7. right? Can he tolerate more? Maybe, but I haven't kind of tested those waters yet. He moves his bowels nicely. A little TMI about my son. But I give him at least 1,000 milligrams a day. And vitamin C comes in so many forms. My son swallows capsules. And so vitamin C comes in powders as well. When vitamin C is in a powdered form, it's ascorbic acid. And that word acid is really important because anything that's acidic is tart, right? Like vinegar, right? It's tart. And so what I often recommend is buffered vitamin C. It's taken out the acidity, so the flavor is a little more tolerable, buffered vitamin C. In powders, and you just mix it, and applesauce is the best medium for everything. That's what all my concoctions in my kitchen when my son was younger was applesauce. So whatever you can mix in water, juice and water. Of course, juice isn't always recommended, but however you can get it in, right? And then glutathione, again, based on the studies for children, I do 250 to 500 milligrams a day of that glutathione. Right? Again, when capsules are possible, right? You can buy it and try to open a capsule, see what you can do with it, but that's what I often recommend. So the phospholipid, right? This again, is a little bit controversial. I know some people viewing this are going to be like, no, phosphatidylcholine is the way to go, which is great. Phosphatidylcholine on its own, right, is helpful. It's the most gloppiest, weirdest consistency stuff, I'll tell you. But I want the complete phospholipid, as I established there, all those other phospholipids. And that's found in what's called lecithin, right? You probably heard the word lecithin. It's often an additive in foods. It makes things creamy and smooth. It's a really easy supplement to give for that purpose. Most lecithin comes from soy. A lot of parents are avoiding soy, GMO, food allergies, many reasons to be avoiding soy. And so they're looking to avoid the phospholipids that come from soy. Oftentimes that pure phosphatidylcholine is from soy. So anyways, there's sunflower lecithin is out there on the market. You can find it loose in a bottle. Again, it's this gloppy, weird consistency stuff. I got soy sunflower once that was loose in the bottle, and I don't even want to call it a liquid. And I decided to just dump it down my drain. It made such a mess of the brush and the whole thing, even with water. So it's an odd compound, but you can get it in granules and powders. Really easy to mix in things. A tablespoon per day, it can cause some digestive upset, loose bowels, so I'm careful with it. I kind of, as with anything, right, this is a good rule of thumb since we're starting to talk about supplements that I use in my practice, is start low and slow, right? Some supplements, you can just kind of go for it because you're not going to cause any real adverse effects. Maybe vitamin E, you can kind of just start at the maximum dose. Vitamin C, because of that bowel thing, you want to go slow, right? The phospholipids, you kind of want to go slow. So as a general rule, I have parents implement literally one supplement at a time. Yeah. Okay. So that is what I have for oxidative stress.